After studying this module, you shall be able to know the meaning of health inequalities, analyze some key facts which point out towards such inequalities, identify the role of class and gender in propagation of these inequalities, understand the meaning of social determinants of health, learn how such linkages work in the context of developing and developed countries. The introduction. Health inequalities refers to the gap or differences in health status and access to health services on account of differences in social classes, gender, ethnic background, and geographical location. Health inequalities exist because of a number of reasons, the primary ones being the lack of economic, social, and geographic access. The differences which exist thus are propagated via health and other indicators to the future generation, and hence it is important from a policy perspective to analyze such differences, find their root cause and eliminate them. Also important is to note is that the differences in the health of individuals may exist because of biological factors, individual characteristic, genetic reasons, but these are not taken into consideration when we study health inequalities specifically. Health inequalities refer to the avoidable difference which exists in the health of groups of people based on the characteristics which are created due to human intervention and actions. And hence inequalities caused as such are representative of certain specific drawbacks in the way the society and economy function. In this module then we will learn about such inequalities in the context of class and gender divide and learn how to address issues related to them. Gender and its role in health behavior, access and outcomes. Gender is an important dimension in the identity of an individual. Any form of gender bias in health is identified as the differences in health outcomes, access and behavior of individuals solely on the basis of their gender. There is a plethora of examples from developing and developed countries of the existence of gender bias in health behavior, access and outcomes. Starting with the fact that a number of developing countries are facing distorted sex ratio, which occurs on account of female feticide and infanticide, which proves the existence of a severe and substantial gender bias. One can only gauge the extent of this bias in other dimensions. With an overall sex ratio almost stable, close to 105 throughout the time from 150 till 205, Asia has long had the highest proportion of males in the world. In 2005, the estimated overall sex ratio was of 107.5 males per 100 females in India, as against 106.8 in China, 106.0 in Pakistan, and 104.9 in Bangladesh. 4 countries that accounted for 43% of the world's population in 2005. Gender affects the developing countries in many other ways. These countries, particularly the ones in South Asia, have strong male preference on account of deep-rooted cultural and psychological factors. And this preference translates into discrimination against the female child even before birth. On account of female infanticide and feticide, these countries face distorted sex ratio. When considering the biological factors, it is female infants who have a higher probability of survival than males. However, in South Asian countries, the female to male sex ratio is less than 1,000, indicating that there is lower than an even number of female to male ratio. Going further, the discrimination is not only exhibited in the distorted sex ratio, it continues after the birth of children. It has been recorded fact that female children are not immunized completely, are taken less often to doctor post-delivery, and are breastfed for lesser duration to increase the probability of next conception, which could be a boy. Such behavior leads to poor health outcomes for female children than their male counterparts, even when the children are as young as a year old. Such disparities continue for lifelong for children and eventually lead to poor health outcomes for female children. There is evidence of this discrimination continuing towards the adolescence and adulthood. Studies have been undertaken to understand more discriminatory practices in the household behavior towards health care and health expenditure of children in the household. It has been demonstrated that female children are taken to the hospital much later than male children after a disease strikes. and households spend significantly lesser resources towards the treatment of female children than they do for male children. In terms of nutritional status and food expenditure too, female children receive less nutrition and are given less healthy food. For certain items of consumption like milk, eggs, meat, male children are given more preference over female children. This bias in the intra-household allocation of resources continues into teenage and adulthood. More nutritious food and better resources for healthcare are devoted towards men in the family, and women have make to do with the leftovers or non-nutritious food. This in turn causes the already existing inequalities to accentuate. In addition to this discrimination, sickness of the females are less taken care of, less money is spent on their treatment, and there is a certain bias in the approach towards the male and female health in general. Such inequalities are found all over the developing countries, rural and urban alike. Research has also been conducted to look for some possible solutions to the problem of gender bias in such countries. The main conclusion that one can draw from such studies is that women empowerment, education, and wage and income earning opportunities for women gradually shift the balance in favor of the females. This change in attitude is a part of the larger institutional change which gradually occurs over a period of time and requires a complete shift from the pre-existing norms and practices about gender. While it is necessary to understand that gender discrimination and gender bias are the basis of health inequalities in males and females, it is also important to note that health inequalities exist between the two genders on account of the biological and lifestyle factors. These factors may not be considered as a cause of inequality, but these factors are also important to study the differences in the health of men and women all over the world. In the developed countries, the instances of explicit discrimination are hard to find for gender either in the households or at the institutional levels in the provision of healthcare services, etc. The gender inequalities that exist in health in such countries occur mostly due to the biological reasons and because of the nature of the lifestyles and long-term habits that individuals have. It has been observed that women live longer than men on an average, report lesser serious health conditions, are more prone to access their own health negatively. Men also tend to have more dependence on alcohol and other habit-forming diseases. A number of other factors also influence the differences in male and female health, like routine of exercise, the lifestyle, eating patterns. In addition to all this, the work pressure and employment work hassles also influence male health more than female health. Mental health is also a concern when it comes to differences in male and female health. The common consensus for mental health is that the females generally face more mental health problems than males do. According to WHO, mental health varies between men and women for a variety of causes. Job stress, work pressure, social pressure, etc. are important causes that affect the mental health of men. Class and its role in health behavior, access and outcomes. The role of class comes into play because of the income inequality playing a role in determining the health access, behavior and outcomes. Income inequality creates relative deprivation of income and hence creates economic barriers to access to healthcare services. The current literature has expanded the meaning of class into few other dimensions. Class in the recent context refers to a number of factors pertaining to the identity of individuals, education, occupation, race, ethnicity, income, wealth and affluence are some of the other characteristics which are included in the socio-economic class of individuals. In this section, three of the most important factors, income, education and occupation, are analyzed in the context of health inequalities. Not only is the relative income deprivation a problem in itself on account of accessing the healthcare services, low levels of income are also associated with low education, information and nutrition levels, which accentuate the problem of access to healthcare services in other aspects. The role of class, therefore, comes with a multitude of issues related to the health of individuals. Below is a brief description of some factual analysis related to the health and income inequality. The role of income in determining the health of individuals has often been described in terms of an income gradient. The gradient refers to the measure of the slope coefficient on the income variable. A number of studies in the developed countries settings have tried to analyze and find the income gradient. Most of such studies consider some or the other measures of health and address the estimation issues related to endogeneity or measurement error to get precise and consistent estimates of the relationship between income and health. It is widely documented that the gradient is an important component of the relationship between income and health, and that across various studies it emerges that the gradient increases with increase in income. The studies also emphasize the fact that gradient retains a significant value even after controlling for other important variables in the estimation equation. There are many ways in which greater income works for the benefit of health in individuals. Richer individuals can afford better healthcare facilities, get adequate nutrition, have better access to resources. Richer individuals are also at an advantage with respect to health because of the greater access to information, and they can better avail facilities like gyms and health clubs. In fact, if some of the recent research is taken into account, greater income starts to show its effect in the childhood itself. A few studies have found that children from wealthier homes and richer parents have better health than their poorer counterparts. Since health is considered a stock variable, this means that better health in children translates into better health outcomes as adults. Research also shows that poorer children are born into poorer health, and this also aggravates the rich-poor health inequality. Since richer parents can spend more on the care of such children, the recovery of richer children is faster, and hence the gap between the rich and poor children doesn't get reduced. Role of education in aggravating health inequality. Better educated individuals are more informed, have more knowledge about ailments and treatments, are more risk averse. Better educated individuals also follow healthier routines, have better nutrition and food habits, and have been found to exercise regularly. More education is also associated with lesser consumption of alcohol, smoking, and habit-forming substances. More educated parents take better care of themselves and hence give birth to healthier children. Effect of occupational structure on health. Another important aspect of the socio-economic class category is the occupational structure. A number of studies have evaluated the effect of the corresponding occupational classes on the health status on individuals. Broadly, the role of occupational or work category on health status can be analyzed in a simple theoretical framework. Individuals who belong to lower strata or work categories are more exposed to risks on the job. It is widely accepted that manual workers are much more exposed to risk of physical and chemical hazards than are workers in white-collar jobs. Certain occupations themselves bring in the hazards to health and fitness. For example, mining workers face much more lung and breathing issues than any other category. Risks associated with low-paying occupation and jobs are also widely known. In addition to this, low-paying occupations are also looked down upon in the society, leading to an added psychosocial burden on the individuals. Not only are certain types of occupations more geared toward health risk, unemployment too is associated with lower levels of health in a number of cases. Unemployed individuals face a number of challenges, including the social stigma of being unemployed. They cannot spend on health and nutrition, and in addition, there is a psychological pressure of not being able to contribute productively to the society. All of these factors lead to worse physical and mental health for such individuals. Instances of active discrimination on the job have also been reported on the basis of race, caste, and other ethnic categories. An important feature of the developing country job market is the high degree of informal and casual employment, which does not offer any kind of protection against injury and health risks. Informal employment also comes with the insecurity of being laid off and does not assure any severance pay or pension or gratuity, etc., which adds to the woes and insecurities of workers. All of these factors make the workers in formal sector more vulnerable to health inequalities. Nature of health inequalities between developing and developed countries. It is an undisputed fact that developing and developed countries differ in the structural arrangement of the economies. Developing countries face a number of structural and financial constraints when it comes to adequate provision of basic services to their citizens. In addition to these constraints, large population, incidence of communicable disease, tropical disease, low levels of literacy in the population accentuate the problems. In this context, it is imperative to analyze what kinds of differences exist in the structure of healthcare system and what repercussions this might have on the health scenario for each type of country. The important differences that arise in the two sets of countries can be studied under basic parameters of disease incidence, disease burden, health behavior and outcomes, health services provision and access, healthcare financing and infrastructure. As mentioned in a number of studies, the disease incidence and disease burden in a developing country mostly pertain to young people being affected by them, and also the fact that most of such diseases are communicable in nature and hence are more difficult to control and prevent. If seen across the developing countries around the world, diseases like malaria, cholera, dysentery, dengue, chickenpox, etc. are common and affect more people. AIDS is the other common disease affecting a lot of people in developing countries. The incidence of AIDS is higher in African countries, and it is not difficult to see the effect it has on their economies. AIDS is considered a huge burden on the younger population in African countries. In terms of differentiating between the health indicators across countries for the health inequality, certain data have been provided by the World Bank. The health expenditure as a percentage of GDP varies vastly in developing and developed countries, from a mere 1.9% in Lao PDR to 17.1% in the United States in the year 2014. The corresponding figure for India and China is 4.7 and 5.5% respectively. Switzerland spends about 11.7% of the GDP as its health expenditure. The variability is also high when one compares the out-of-pocket health expenditure for the same countries. While in the US this figure was 21.4%, the same stood at 78.8% for Lao PDR. The corresponding figures for India and China are 89.2 and 72.3 respectively. The life expectancy among different countries varies too. In 2014, the life expectancy was the highest in the Euro areas at 82 years, whereas the sub-Saharan Africa experienced the lowest at 59 years. The infant mortality rate stood at a low of 6 and 4 per 1,000 live births in the United States and France in 2015, whereas the same was 26 and 67 for Dominican Republic and Cote d'Ivoire. India stood a middle ground at 38.59% of children under 5 were anemic in India in the year 2011, whereas the same figure stood at 19 for China and at 14 for Italy. These variations suggest that there are marked differences between developing and developed countries when it comes to health policy and making investment in the public health. Consequently, the health outcomes vary considerably between the two sets of countries. Summary. In this module, we have tried to analyze the role of gender and class in propagating the inequalities in health behavior, access and outcomes in developing and developed countries. Gender and class play different roles in developed and developing countries to affect health behavior, access and outcomes. Therefore, it is necessary to analyze such factors in different ways in developed and developing countries. In the context of developing countries, there is a significant difference in the health of males and females on account of the gender bias and discrimination that the females have to face. The instances of such discrimination start even before the birth of children. Sex-selective discriminatory behavior leads to extremely poor health outcomes for girls, and these continue over the lifetime of individuals as health is a cumulative variable. In the developed countries, the instances of active discrimination are nearly absent. However, the difference in the health status of the males and females emerge from the biological factors and the associated behavior and differences in the lifestyle. A greater proportion of males report addiction to alcohol and other habit-forming substances. Similarly, more men are affected by the cardiovascular and other non-communicable diseases because of their food consumption habits and lack of physical activity and exercise. The role of class emerges in generating the health inequalities via the income inequality. Income inequality leads to relative deprivation and reduced economic access to quality food, healthcare services and medication. It has been widely noted and accepted that people belonging to lower economic strata are also illiterate and have lesser access to information. In most of the scenarios, they also belong to the lower social strata and are discriminated against. Another important field of study that has emerged in the recent literature is the effect of social or socio-economic classes on the health of individuals. The socio-economic classes refer to a range of classes of an individual's identity in the literature work and occupation categories, race and ethnic identities, education levels, and income and affluence status of the individuals form some of these classes. A wide variety of literature on this topic throws very interesting results in terms of how one can quantify the effect of all these variables. But the most important conclusion that one can draw from this, people belonging to lower strata and having lower socio-economic standing are deprived of adequate means to stay healthy, and a multitude of factors contribute to this. In the above discussion, income, education and occupation have been explored in detail. The social gradient of health represents the marginal impact of the change in socio-economic status on the health of individuals. From a vast expanse of studies, one can safely conclude the existence of an income gradient, and that an increase in the number of years of education leads to healthier lifestyles and better health outcomes for individuals. In the case of occupation categories, one finds that workers employed in manual, informal and contractual jobs have no job security or coverage against injury or have social security of any kind. Thus, they are more likely to suffer in terms of health outcomes. Equally important is to note that being unemployed or employed in a lower class job contributes towards mental stress and psychological pressure, which lead to deterioration of mental health. In the final section, we study the differences in the structures of developing and developed countries. Based on a few data figures from the World Bank, some comparisons have been made in the health outcomes and other health indicators of both sets of countries.